proteinuria, hypergammaglobulinemia, where you have IgG levels should be more than 1700. So some other additional findings, additional lab findings you can be helpful, but it's not required to make the diagnosis. So elevated IL-6 and the soluble IL-2 receptor and VEGF, IgA, IgE, LDH, and beta-2 microglobulin. Bone marrow, typically you find polyclonal plasmacytosis. Sometimes you do find a minimal reticulum fibrosis, but it's not very prominent. So these are the minor criteria. So next one is the exclusion criteria. What all things we should exclude? So first we exclude, there are other disorders that can have a clinical pathologic features very much similar to MCD. So in first one, let us kind of look into autoimmune disorders. In autoimmune disorders, we have to exclude rheumatoid arthritis and SLE. In rheumatoid arthritis and SLE, even though the autoantibodies associated with them can be seen in MCD. So you have to resort to other clinical features to rule out autoimmune disorders like SLE and rheumatoid arthritis, juvenile arthritis. And some another thing is like IgG4. IgG4 can have morphologic features similar to Castleman disease, where you have just having a high level of serum levels of IgG4 does not mean it is IgG4 disease. You have to have a high IgG4 to IgG ratio and like a very characteristic features. And when to rule out when malignancies, among malignancies, one of the things which is important to rule out is interfollicular Hodgkin lymphomas. Interfollicular Hodgkin lymphoma, you have Hodgkin cells can be sprinkled into the interfollicular area. It's very important to rule out. FTC sarcoma, that is typically can be associated with kind of morphologically can be associated or similar to stroma-rich Castleman disease. Poyme syndrome and HHV8 is discussed by Dr. Chadbourne. So you know how to differentiate from once you remove Poyme's associate MCV and HHV8 associate MCD, you can remaining MCD we can kind of put them in the idiopathic multicentric Castleman disease. One another infections we probably want to rule out is EBV and HIV. Mostly chronic EBV and HIV stages tend to show MCD-like morphologic features. So these are the exclusion criteria. So once we get minor criteria and major criteria and exclusion criteria, patient who meets all three criteria, like major, minor, and exclusion criteria, we basically give them a affirmative in idiopathic multicentric Castleman disease. So for major criteria, I want to kind of repeat, like minimum grade should be 2 or 3 grade for ectopic GC and plasmacytosis. That particular information should be provided by the pathologist. And the second point in the major criteria is multicentric lymphadenopathy. It's more than 1 centimeter in size and should have more than 2 lymph node stations. That information is provided by the clinicians. Minor criteria, at least 2 or more abnormal clinical and lab finding. In this, at least 1 lab finding should be included. And exclusion criteria exclude all the IMCD mimics. And if some of the patients, it does not meet the major criteria and exclusion criteria, but does not meet the criteria for minor criteria, then you can probably kind of give them a probable IMCD. With all these things given, it is pathologists still have a challenge to make the appropriate diagnosis. The most common challenge we always face is inadequate tissue or needle core biopsies, or sometimes clinicians we may not get the clinical information, and histopathology is not very specific. And another One interesting thing we tend to find is variable histopathologic features in the same patient